Welcome all to the Bergen Exchanges on Law and Social Transformation and this last event for the day, where we're going to think about legal determinants of health inequalities, what the pandemic has shown us, and how we can rethink health systems beyond the pandemic. And my name is Siri Gloppen. I'm the director of the LawTransform, the Center on Law and Social Transformation, and which is one of the organizations hosting the Bergen Exchanges. This particular session is hosted by BCEPS, the Bergen Center on Ethics and Priority Setting. And I'm here on stage with Kjell Johanssen, who's a professor of medicine and works at BCEPS, and he will be sharing his experiences from working in Zanzibar, but also globally. And we'll also joined digitally by two excellent presenters. One is Alicia Yamin, who's joining us from Boston. She is a global fellow. No, she's a senior fellow at the Peru Center at Harvard Law School. She's also a lecturer at the Harvard School of Public Health. She has a position as an advisor with Partners in Health, and she's also a member of BCEPS, of the staff at the BCEPS, and also at LawTransform. So she's a great friend of the Bergen Exchanges, has been with us from the first very start 8 years ago. And she has been working both globally with global health governance, advising many bodies, but also working locally. So we're really looking forward to hearing her introduction to this and keynote to this seminar. Also joining us from Peru is Camila Gianella, who is a senior researcher at the Disinformation Institute here in Bergen. And Camila is a social psychologist by training, also a training in public health, and has worked widely. She has a broad experience that sort of shapes her lens, looking at health systems in particular, and also health systems in the pandemic. And as many of you will know, Peru is one of the hardest hit countries in the current pandemic. So we have an extremely knowledgeable and intellectually sharp panel who will help us think through these very complicated questions about what we can do. Yes, and we have a third. I'm sorry, we have a third scholar joining us globally and digitally from Brazil, Danielle Rached, who's an associate professor at FGV University Law School in Rio de Janeiro. And Danielle has worked a lot on international health accountability and will inform us both about the situation in Brazil and help us think through how we can improve health governance at the global level. So this is a wonderful panel, and we're also joined by a nice audience here in Bergen Global, many of them studying global health at the master's course at the University of Bergen, and also by our global PhD students and others who have joined. So welcome all. I want to start by giving the words to you, Alicia, to take us through some of the challenges that we're facing. I think actually we can't. You need to. Oh,
thank you. Thank you so much, Siri, and thank you for the introduction. And I can only say I'm sad not to be there in person. For the PhD students and the participants, this Bergen Exchanges, which Siri has put together, is really an extraordinary and exceptional event, academically, and also because it's not just about sharing ideas across disciplines in a horizontal way, but also it's woven together many relationships and collaborations, certainly that I've had over the years. And I think it's really quite rare and special. And I'm sure all of you are feeling that, the ones who are able to be there in person, but it's something that you will hold on to and build on from this experience going forward, I'm sure. So I'm going to share screen and go through a kind of whirlwind overview of some of the problems and try to be quite provocative. Wait, no, that's not what I want. Sorry. Is that better? Can everybody see that? Okay, I want to start. It's funny that the slide thing doesn't work the way it usually does on PowerPoint. I want to start with saying that, before COVID, we faced a series of conjoined crises: ecological, political, social, economic, and this health crisis has made all of those evident. But I think my own view, my starting point is that the root of those conjoined crises is the financialized, globalized, neoliberal form of capitalism that is not just an economic system, but really shapes an institutional social order and has a variety of different ancillary conditions that are necessary to sustain it, including extractivism, environmentally extraction of cheap labor within countries and across countries, unpaid social reproduction and care economies. So that's my starting point, that really these things are interlinked, but I'm going to focus on health systems. So when COVID struck, when SARS-CoV-2 struck, we had an evident climate crisis, not just a looming climate crisis, an evident climate crisis. Many countries in the global south were shackled with layers of debt and austerity. And that is also the case in the United States, where we have a federalist system. Many of the states found that neoliberalism had permeated down to their level and their capacity to respond. Privatized and or underfunded health systems, an increasing trend toward biomedicalization as well as medical care alone versus public health. We saw that. Decades of loss of social protection and labor rights, labor flexibilization, which is part of structural adjustment, and profound social and gender inequalities. And we had come to take for granted that the private sector was going to solve our problems, and capitalists like the Gates Foundation. We were obviously facing a shift, a drift toward illiberalism, a crisis of liberal democracy and multilateralism. And the story that I'm going to tell is not that populism is the opposition to human rights. The story that I'm going to tell is that it is because economic and political institutions stopped delivering on all of the promises they were making, including on economic and social rights, that people lost confidence. And after the 2008 global economic crisis in particular, and the austerity imposed, that breeds a turn toward populism. Okay. So these are four narratives that I'm going to focus in on with that larger context in the background. The Great Leveler is really the Great Inequality virus. Pandemic preparedness does not come from global health security. It's not science versus politics. Health is always political. And the foundations of global governance for health have not been shaken by this pandemic. They've actually been revealed to be the colonialist foundations that they really are. So first, I think we all know this now. What at the beginning people were saying is the Great Leveler has obviously not been the Great Leveler. Populations within countries as well as across countries have fared very, very differently in this pandemic, and Oxfam came out talking about it being the inequality virus. Now, that's not new. All epidemics and pandemics illuminate inequalities, right? And are sort of social x-rays. But this one in particular, because of its breadth and scope, and it has not just fed on this underlying pandemic of social inequality, but it is exacerbating them. It will thrust many, many hundreds of thousands of people into extreme poverty after this. So what do health systems have to do with this? Well, I'm just going to give an example of the United States, and I have to apologize here. I'm embarrassed to show this in front of Siri. I put this together this morning before the talk, and Siri has the most incredible charts with arrows all over. So yeah, just that statement. So in the United States, we have extreme wealth and income inequality that is racialized, right? That interacts and intersects with structural racism. That affects where people live, the neighborhoods that people live in. That in turn, because of the way our education system is structured based on local districts and property taxes, affects access to education. It also affects access to employment and work conditions. And because we have a health system that is based on employment-based insurance, work conditions affect access to healthcare, including in this pandemic, testing and treatment, clearly. But those underlying conditions, those social determinants, affect exposure to the virus, chronic diseases like diabetes, cardiovascular disease, what we call allostatic loads. The wear and tear on bodies is not something that is within human beings. It's very much affected by the external environment. And all of this then leads to much, much higher rates of severe disease and mortality among people of color in the United States than white people. Now, this is not new, right? Throughout the history of this country, there have been extraordinary disparities between white people and people of color. For example, in tuberculosis at the beginning of the 20th century, those disparities between whites and blacks were replicated at the end of the 20th century in cardiovascular disease and cancer. Maternal mortality is up to 4 times higher in women of color than it is among white women. The health system reflects and refracts back these patterns of discrimination and exclusion in the overall society, and punishes, I would have said before this pandemic, in particular because of women's reproductive roles, because of their caretaking roles, women are particularly affected by these inequitable health systems. But now it's clear in a much broader way how this functions. Global health security, which is all the fad, and we're going to go into a state of drawing up a pandemic treaty now in November, probably, that is being fast-tracked as we speak. will not address all of the systemic failures that we have seen in COVID. And the United States was #1 in pandemic preparedness, and the UK was #2, and we saw what a sham that was. And all of the reasons underlying that would not be changed by a narrow global health security paradigm. I think among this crowd, I don't need to go into why health should not be a national security paradigm, why cooperation is actually more important than go-it-aloneness. But it is, I think, worthwhile pointing out that the international health regulations and building on what is there and on the so-called disease surveillance efforts and capacities there, as well as the so-called core capacities, will not address and the kind of response we need ongoing in COVID, but also for future pandemics that we know will arise. We've seen that primary healthcare systems are the first line of defense against outbreaks, and that referral systems are also necessary, right? And the United States, again, has an absolutely terrible record of investing in hospital networks, but not in primary healthcare, not in public health. The Commonwealth of Massachusetts, which is quite a small state in the United States, has over 350 local, completely underfunded public health departments, which made contact tracing and support during the outbreak of the pandemic extraordinarily difficult. And other states are worse. So building primary healthcare systems and healthcare systems obviously needs material investment. And in much of the world, that means closing the external funding gap. We hear a lot about what countries should do and what percentage of the budget should be allocated to health, but there's just not enough fiscal capacity, and structural adjustment has starved those countries of fiscal capacity. So this comes back to a structural problem in human rights, which is about the dyadic relationship between the individual and the state versus development, macroeconomic development, which is not governed by those kinds of processes and structures of accountability and equity, et cetera. And I think this is an inflection point where it is worth pointing out or worth thinking about, why we drifted to human rights. Was that a palliative after we ignored the new international economic order in the 1970s? And I also think, being in BCEPS, we do a lot of work on equitable priority setting, and which I'm extraordinarily proud of being associated with. But there is also, and Ulla Fritjof says this all the time, you can't have equitable priority setting without equitable financing. And in the world we live in, you can't have equitable financing without changing these rules of the global order, right? So it's not science versus politics. Health is always political. This fellow in the corner is Rudolf Virchow, the father of social medicine. When he gave his famous report on the outbreak of typhus in Upper Silesia, he laid out very clearly why fighting epidemics needs to be done through politics and not just through medicine, right? And throughout history. I mean, I'm very glad Danielle is on the panel because the fight for the SUS in Brazil was part of a fight for democratization and democracy building. But since the latter half of the 20th century, and certainly in the 21st century, health has become increasingly isolated from democratic scrutiny. It's considered somehow separate, somehow apolitical, subject to this special kind of scientific expertise. And that has led in this pandemic to public health experts, infectious disease experts, epidemiologists like Devi Sridhar, who I respect very much, saying, the reactions are, it's like being on a plane and the engine doesn't work. Everyone gives their opinion on what should happen instead of trusting the people who have engineering experience and have done that for years. And I disagree fundamentally with that. I think there have been enormous blind spots in the public health expertise advice on what to do. The mathematical modeling, the models that have come out from IHME have been wrong as much as they've been right. So, I think we have to take a step back. But first I want to say, this is also not new. This is not something that just happens in pandemics. Health systems reflect and refract back fundamental normative values all the time. Health systems, by the manner in which services are financed, the provision of differentiated or universal entitlements, how patients and providers are treated within the system, and the kind of transparency and accessibility of information is all reflects values, normative values. Those are not technical decisions about how to move along these different axes. They are fundamentally normative decisions. So in this pandemic, in all crises, politics grows more intense, right? And we've had infodemics, terrible campaigns of disinformation, misuses. And I want to be very clear here. I am not talking about Trump. I am not talking about Bolsonaro, who obviously deny reality. I'm not talking about that. But I am questioning what kind of information states have provided, whether it's really effectively accessible, whether it's been translated into indigenous languages, which really didn't happen in Brazil or Peru, and we've seen some of the effects of that, whether it's accessible cognitively, whether people understand what does social distancing mean? What does when your pulse ox gets to a certain level, you should seek attention mean? Is it actionable? What does social distancing mean to people who live in favelas or RIMAC in Lima or the Cono Urbano de Buenos Aires? Not too much. And there's also an issue of the trust in the source of information. Why should we expect people who have been betrayed repeatedly by their governments to suddenly respect and believe what the health system and what the government officials are telling them? I think that's quite fanciful, actually. So I very much support this idea of a colleague of mine at Harvard, Sheila Jasanoff, who is a wonderful historian of science, who talks about how really we have, and this is before the pandemic, but she's also done amazing work during the pandemic, on how the technologies of hubris, this idea that our public health expertise should guide specific policies always, should be replaced by technologies of humility, where we are willing to openly listen to different perspectives. And part of that is processes for decision making, right? And we work a lot on this in BCEPS, where we advocate transparency on rationales, transparency about uncertainty, empirical and normative, because there aren't always normative consensus about priorities. An openness to include diverse perspectives, including those of marginalized and disadvantaged populations, and to change, to shift, to pivot course when things don't go as planned, and regulation and enforcement of these promises. And I would add here, because this is something that we've come across, and I'm working on an article now with a number of people at BCEPS on attention to structural subordination, because it's not enough to set up some sandbox where you ask different people what their opinions are, not considering how the power dynamics in the of a larger society are reflected in that structured participation and deliberation exercise. Those don't get checked at the door of a deliberative process. So finally, there is a narrative, maybe I'm especially hearing this because of the world I circulate in, that this has shaken the foundations of global health governance. And I think that could not be further from the truth. I think it has revealed the foundations of global governance for health as profoundly colonialist, with an architecture that is profoundly neoliberal. As I said, there have been decades of trade liberalization, financial deregulation, and the tightening of intellectual property rules. Decades that has affected health greatly. From about 2000, we see a privatization and an undermining of committed contributions to the UN, and the UN really cedes its leadership authority to the World Bank and the IMF. More private sector financing of WHO through the framework for engagement with non-state actors. The Gates Foundation comes to play an outsized dominant role. Again, around the same time with the MDGs, we see this nested cluster of goals and indicators, targets and indicators, which is really a kind of adoption. I mean, we can agree with many of the Millennium Development Goals. We can agree with universal health coverage, but this kind of governance at a distance very much replicates the kind of governance at a distance that has happened through structural adjustment, where from the center, countries are judged on inflation rates and basis points, etc. That is fundamentally de-democratizing. And again, and it's also sets up a system that is highly unaccountable. I was on the Secretary General's Independent Accountability Panel for Women's, Children's, and Adolescents' Health. We tried desperately to impose some kind of structures to look at funding commitments and outcomes. It's very, very difficult to do that when you can't match source, channel, and program area in the way that global health is funded. And so the response to this is now, I think, I want to suggest that it is not what is prevalent in terms of suggesting more focus on international health regulations that are not the kumbaya solution. It's not the human rights have been incorporated into international sanitary regulations. It's really not that, and I'm happy to expand on that. And the idea that we would achieve human rights through global governance, I think, is really misguided if we care about democratization. And I'm happy to talk more about that as well. So I'll go through this quickly. I know I'm running out of time. So this is the kind of proxy for the really kind of horrific global inequality that we are witnessing, right? And I want to debunk a few common ideas. One, the development of vaccines was not due to the ingenuity and nimbleness of the private sector. The development of vaccines was heavily publicly subsidized. Billions of dollars have gone into research on coronavirus in the United States alone, $1 billion into Moderna's mRNA vaccine. COVAX versus CTAP, all of a sudden, when actually global public investment seemed to work, public investment and then global public investment through CEPI, but then in the distribution of vaccines, we came up with this very palliative, ridiculously short-term, mitigating crumbs to the poor system in the COVAX facility, which pooled vaccines instead of going with a COVID technology access pool, which would have aggregated technology and know-how. And that decision was largely driven by Gates. So you see what happens before playing out in COVID. So I work, as Siri said, I teach law and public health and actually bioethics at Harvard, but I also work about part-time with a global health and social justice organization called Partners in Health. we are advocating very strongly for the TRIPS waiver. The idea that TRIPS flexibilities are sufficient in a global pandemic is really ridiculous, and I'm happy to talk about that, but also not just the TRIPS waiver, know-how transfer and the decentralization of manufacturing and production. It is horrifying that in sub-Saharan Africa, there are just fill and finish facilities, and they have to rely on importing vaccines. And in much of Latin America as well. That has to stop after this pandemic. We have to learn the lessons that we've seen so clearly. So again, I think that my colleagues in global health law and human rights need to think harder about not just the harmonization of international law, like sticking core obligations in General Comment 14 onto core capacities in the international health regulations, but the harmonization of international law in TRIPS, for example, where we want countries to be able to declare national emergencies so that they can invoke those flexibilities, and how that needs to be harmonized with the IHR. So I'll finish here on what is to be done. Siri asked me about what do I think going forward, and what is the role specifically for human rights in relation to global health. So there's sort of two different questions that I've been mixing. One is how human rights functions, right? How it functions to affect social change. And the other one is how effective it actually is on addressing social inequalities. And on the first, I want to emphasize that I have a view of human rights that is neither just social movements in country, but it's definitely not this top-down human rights-based governance. It is a dialectical process where, as a keynote speaker in Bergen Exchanges, Sally Mary talked about a few years ago, and sadly she has subsequently passed away. The universal concepts of human rights are vernacularized, are made concrete, are adapted and used by a number of different institutional actors in countries, and that there's a recursive dialectical relationship with standards set at international level and the work at national level. That requires not human rights-based approaches that are checklists and filling out and mainstreaming in global institutions. It requires legal mobilization that is embedded in broader social and political movements. And here, this, I have to say, is not my design because, as you've seen, I'm not capable of doing such nice graphics. This is borrowed from the AIDS movement and somebody else's PowerPoint. It also means a much greater focus in human rights on systems, on democratic systems and institutions, and on the infrastructure, the fair and equitable infrastructure of provision of services at local levels, at national levels, and at international levels. It also requires some reuniting of human rights and development finance. I am a part of the expert working group on global public investment, which I'm happy to talk about. Nikolai Hegerton actually has an article today or yesterday in a Norwegian periodical, the name of which I won't be able to pronounce, but I'm happy to also talk about that, which is moving from this colonialist version of top-down charity aid to a longer-term strategic investment, somewhat like the Global Fund, where countries have a say, all countries invest according to their ability and receive according to their need. And it is a way to democratize some of development finance. Not a magic bullet, but a step forward in my view. It's not enough. We also need to challenge those rules of the game, the neoliberal intellectual property, the financial deregulation, the decimation of unions and labor, and lack of social protection infrastructure. And I want to end on this. I also think that part of that institutional social order I started with depends on the fragmentation of knowledge, on epistemic fragmentation and siloization. which impedes collective action, which is why I think we need more research networks across disciplines and borders, and why, again, BCEPS and the Center for Law and Social Transformation are so very, very special and exceptional. So I'll stop there, and I'm really eager to hear what my colleagues say.
Thanks a lot, Ali, for this tour de force of sort of showing us how as you're saying, the pandemic exposes. It didn't create the problems in itself. It exposed sort of inequalities, but it also sort of pays attention to how we need to pay attention to how the pandemic landed in different structures, different health systems around the world, and also how these systems are embedded in social inequalities, social systems, and in some cases exacerbate them. In other cases, maybe can make them less of it, depending on how the health system is. But also, and I think that is also important to what we'll talk about, that national health systems are also, they're not only sort of depending on what's happens nationally, but they're also conditioned in different ways, very different ways by the global health governance, but also by the global economic system. And of course, power is central to this. So this was amazing. This was really good. We really, really want you to participate. Also, those of you who are master students, also those of you who are online. So if you have Alicia talked a lot about very complicated things. So if there are things that you don't understand, please ask. Because being very interdisciplinary, I think it is, even if you're very knowledgeable in one field, there might be things that you can't quite make sense of. So please don't be afraid to ask. If you can't get it, probably somebody else can't get it as well. And also, if those of you, if you want to come in to more easily participate, you're also welcome to. Those of you who are.
Yeah, we have some of the audience behind the
glass wall.
So we're just
Alicia
encouraging them
Camila and Danielle all know.
Come in, because I know many of them have a lot of interesting stories. So
yes.
We should.
So we want to hear your stories as well. So please do. But before if any of you have any questions at this point? No? If you do at any point, just raise your hand until you get a nod, and then we'll come back to you. But I want to go first to Camila, because if some of us are like compulsive readers of statistics on COVID, and then we see that Peru is particularly hard hit. Statistics is always, unreliable, but I know from our conversations throughout that it has been a very, very severe situation. So can you sort of say something about how this picture that Ali was drawing up, how that sort of reflects the Peruvian situation?
Thank you. I'm really missing the program now and the opportunity to be with all of you. Well, when this started last year, when we started to be concerned here in Peru about the COVID, we were super concerned. We were absolutely aware about the situation of the Peruvian health system. When we saw these overcrowded hospitals in Europe, that is the situation of our hospital in a daily basis without the COVID. So, and we were aware that we didn't have the welfare system, and so with some colleagues we were really concerned about what was going on and what will happen with the country. I recall that in March we had some meetings with the people from CMI and say, yeah, but Peru is not performing so bad. Ecuador is worse. And I say, yeah, but this is a dynamic situation, and this is moving around, and also we don't have accurate data, and this is going to be bad. No? And people say, yeah, but you has been performing so well on the global development indicators and health indicators and that. And I say, yeah, but we will see the limits of these kind of indicators when with the COVID, and it's something to concern. Because in terms of these development, sustainable development indicators, Peru was on track on maternal mortality, Peru was on track on universal health care, because the indicators are not really assessing the capacity of the health systems and the society and the state to provide people, to protect people. And I think that the COVID has exposed that really dramatically in the case of, in many cases, and I think in the case of Peru especially. So, and what we have been seeing is, like, I will focus on now in the thing of the vaccines, is that after 1 year when we were just waiting for the vaccines and trying to follow up what was going with the vaccines, and the vaccines were coming, and all these people speaking about inequalities, and we were still in some kind of lockdowns with the schools closed and all that. When the vaccines come all this neoliberal idea that I have the right to buy my vaccine, the state is crap, the state is inefficient, I need to run and save my life. And that shows that the people with power is started to go to the United States to vaccinate. And I think the thing is interesting in these countries is that the people that design the policies are designing the policies for the poor, you know, so the poor, but they don't use public services. They don't trust in public services. They don't believe in public services. And with the vaccination, that shows, like, with a lot of clarity, because people were not going to wait. A lot of them went to the United States, or were asking to the vaccination to split, to segmentize the vaccination. So we need the vaccination for some people that have formal job, then the clinics, and then you just vaccinate the poor people. But we don't want to be in the same space in a way. And that is how the vaccination started in Peru in March. And that, without any logic, we have a segmented vaccination campaign, where if you were a poor person without formal job but has been a hard worker, or just taking care of, I don't know, but you were 80 years old, you were not having access to the vaccine as fast as a person of 70 years old that used to have a formal work. And that was justified, and people were happy with that. Medical doctors were vaccinated at their own facilities when they were retired medical doctors, and that was okay for the group of medical doctors, without any critical approach of why you are allowing this segmentation. And in the country of Peru, is because that we are used to the segmentation, and in a way, it's justified the segmentation. And to put that in the table is almost impossible, because people don't want to listen. Don't want to listen when you speak with these people that present themselves as good, as policy makers, and they are making policy for the poor. And they don't understand the power imbalances that are in the policies that they are designing and intervention that they are designing. At the end, since April, because the vaccination campaign is universal, so if you are poor or you are rich, you go to the same vaccination center. And it's working well. People is okay with that. But now we have the problem with the schools, because the schools are still closed in Peru. So there is a debate on how to come back to schools, and they say, yeah, it has to be volunteer schools, and the school has to fulfill some requirements. Yeah, and these requirements, most of public schools are not able to fulfill these requirements, but private schools, yes, because some private schools can fulfill this. And again, no debate on how to improve these policies, these regulations, to allow to most of the people, or to have a vulnerability approach to say how to target the kids are more in risk and are more vulnerable and has been mostly affected by this. All kids are affected, but there are some that are having harder than others. There's no debate on that. So I think that one problem that we have here is that the elites that make the decisions are really neoliberal. They think that you need to buy the things. There is no trust in the state on public services, and they design the policies for the poor and not for them. And when they are affected by the policies, is no. Then I try to make something for me that saves my group of people, and no you. You guys are poor. You don't work. You are lazy, and all these scores emerge, and then we are in really huge problems. And unfortunately, we have not been having, I think, a broad discussion on this, and people is still super uncomfortable when you are speaking about power imbalances, privilege, and that kind of stuff. People just get crazy when you mention this. Yeah, I would say. And another thing that Alicia said, that the public health experts, and that in the case of Peru, I think that the public health experts they're trying to influence some of the decisions, but here is the economist that has been deciding most of the things. And the economist has been calling to open activities and that's okay, because you need the economy to move, but without any protection. So the market is going to save us. Mm-hmm. Even though there is there are many signs that the market has this market approach has put us in this situation, there's no critic to that. And the market is going to regulate everything now. So I think that is also a thing to think here in the region.
Thanks a lot, Camila. Thanks a lot. I think this shows us some really important things, and I'm sure that many of you recognize some of this picture. For instance, that those who decide don't really use the systems they're designed for, which I think is common in many countries. But also that there is really that the market solutions are in a way the default that nobody really questions. But Gianella, you've been working in Zanzibar, which of course is also sort of Tanzania in a way, which is also has been a particular place during the pandemic and is a lot poorer in terms of economic resources than Peru. Could you say something about, we hear a lot less from Zanzibar?
Yeah.
So could you just tell us something about how has this played out in the context?
Yeah, thank you, Alicia and Camila. I really learned a lot, and I really like both your presentations, and I'm overwhelmed. I don't know what can I contribute with here, but I can talk a little bit about Zanzibar. We have a project in BCEPS that I'm leading together with Omar Mwalim, and he was a master's student like many of you here at the CIH, and now he's leading this project with me, where we are working with the Ministry of Health in Zanzibar, because Zanzibar, I don't know how much you know, except of nice beaches and really
nice doors.
A nice place to be. Nice stores in Stone Town. Zanzibar is a beautiful place to be, but it's also like any other low-income country. They have their own Ministry of Health, even though it's under the United Republic of Tanzania, but they are kind of semi-autonomous, and that makes it an interesting place. They spend around $30 per capita. I don't know how much it is in Peru, Camila, on health. $30 per capita on health per year. Do you know the number in Peru? I would guess around $1,500 per capita. So you have much more resources.
Lower.
500?
Yeah.
Okay, 500. It's 10 to 15 times higher than what they have in Zanzibar. And what makes it also extremely challenging, and this is common in all low-income countries, is that 50% of the health budget comes from donors. So you can imagine, and so then the structural problems that Alicia points at is really important. How can they be autonomous in making their own priorities, deciding what should be high priority services during the COVID pandemic? How should they take care of the more essential services that are maybe more important than COVID? How can they make sure that people have safe births, that their children gets vaccinated? How can they prevent resources being dragged from these very important life-saving programs into maybe less efficacious COVID-19 projects? But in BCEPS, we have worked in Zanzibar for 5 years together with the Minister of Health. And during that period, we started the project in revising the essential healthcare package. And that is sort of defining the core healthcare interventions that should be given really high priority over the next 10 years and how this should be financed. Because we see patients pay a lot to get treatment. If you break your hip, you have to pay between 10 and 12,000 Norwegian kroner just to get the prosthesis. The surgery is free, but then you can imagine if you have less than $2 per day and you will not get that very important operation. So financial risk protection is important. But during the period of this project for 2 years, there has been now, it's the third principal secretary. Last week or 2 weeks ago, they fired the principal secretary, the sitting principal secretary. And this has been during the COVID pandemic. So they will now get their third principal secretary, and this is a very important political person in the health system. And they also fired the director general in health, and they will get a new director general. So there is a lot of, well, the reasons, I don't know. It's quite fresh news. I got them last week. I don't know the reasons why this person was, why they now will get a new director general, but this makes it extremely complicated to make long-term plans. But I think that is what we aim for in BCEPS in the Zanzibar project, trying to make a plan that can be sustainable over 10 years, maybe longer, where you have these political fluctuations, conflicts, and our experience is that education, having knowledge, doing a master's like you do is very important, because then you have people in the system that knows the technocratic things. They know a bit about modeling, and they know what Alicia talks about, that this is also political. You need to engage with the public, and they know how to do it. So the report in Zanzibar that we are working on, we worked on it for 2 years, will be finished now this fall. And then we will hopefully have we have evaluated 300 health interventions, from safe abortion to safety belts to rheumatic heart failure surgery, and we will have a list of top priorities. And hopefully this can survive through a very unstable political situation and be also important tool when you have the pandemic. Yeah.
Just a small question. So I think a lot of people know that Tanzania was in a very particular situation, because the former president, who allegedly died from COVID, he was sort of denying that there was any COVID in the country. Did that affect Zanzibar as well? Heavily.
And he died in Thailand, by the way. He did not die in Tanzania in the health system he was responsible for. And we very often see that. High-level decision makers, they go to the health system, as you said. But this affected the Zanzibar health system a lot. Even though they have their own Minister of Health, they are dependent on policies from mainland, as they say. There are 65 million people in Tanzania and around 1.5 to 2 million in Zanzibar. And I got the phone call when the 2 months out in the COVID outbreak from the then Director General, and he asked me, can you please give us a small mini lecture on what the Swedish model is? Because they had been told by the politicians mainland policymakers in mainland that now we are going for the Swedish model, and what they understood the Swedish model to be was to ignore COVID. And of course, the Director General in Zanzibar was a bit skeptic. Is this really the Nordic or the Swedish model? And we had a very interesting discussion about the word and the information they got from mainland and how they understood it and what actually the Swedish model was, because it's not ignorance. It's there are interventions there, but that's one example, and also.
But I do think that's how Norwegians think about the Swedish one.
Yeah, they do, but it's not.
No, I know.
They do things as well in Sweden.
Yeah. No, but thank you. So I think, I mean, you're in a way telling the same story from a different perspective, but I think that some of the things that you're also pointing to is also this, and throughout is that. So of course it's who the health system works for, but also sort of how the normal functioning of the health system is affected by the pandemic, which is of course also somebody's decision. And another country that has had a lot of focus during the COVID pandemic has of course been Brazil. And I would like you, Danielle, to both tell us something about the situation in Brazil when you hear what Camila is telling from Peru and also from Zanzibar, and also because you have worked so much on global health governance, say something about how you see this.
Well, first of all, thank you very much, Siri, for the invitation. It's so good to be at Bergen Exchange. It brings so many good memories. And also, thank you all the panelists and Camila, Kjell, and Alicia for giving this so super critical overview of the global health. And I think we really need to get some points for Alicia to explain it further. So about her vision of the future of global health, I mean, where human rights should be. I think it was particularly very interesting, the fact that you said something about the securitization of global health. So we really need to think about these lenses, how the securitization lenses is very bad for global health in general. Also, the Gates Foundation, the philanthrocapitalism, their view on what's good or bad to funding. So we should really explore that further. And last, the TRIPS waiver, that Brazilians were against it, going against our tradition for the emergency of this vaccination. So there are so critical points that we need to get better. So in global health in general, but I'm going to say a little bit, and since Alicia said something about SUS, so that's what I'm going to say something about, and about the Brazilian response to COVID. I think it just gives concrete examples of what Alicia was saying, global health, what has been happening here in Brazil. Because I think, after all, that Brazil provides this very clear example of the risks posed by populism today. So, and the problem that I see is that our government, Bolsonaro's, he managed to alienate the potential benefits of law, the legal determinants of health, which happens when law is used to reinforce the governance of national and international health institutions, and when law implements evidence-based health interventions. So it's not, you all know, of course, that Brazil was ranked as one of the worst responses to COVID-19, right? So just to illustrate this point, we had this article that was just published at Public Health Journal. That was, that the title was among the lines. That was, I thought, that was very precisely the case of Brazil. It's governing COVID-19 without a government in Brazil. So that was our case. But saying that Brazil had a very bad response to COVID-19 came almost as a shock, because from the beginning, Brazil was very it was considered one of the best positioned developing countries to tackle this sort of emergency. And according to this Global Health Security Index, that's an index from Johns Hopkins University, Brazil came, for example, as 22nd among 195 countries in terms of health security, and it was the 9th on rapid response and mitigation of an epidemic. And the main Brazilian asset here, as Alicia was saying, was our SUS, this state-funded single health system that we have. So SUS has this constitutional status. It provides for a free and universal access to healthcare to almost 210 million Brazilians. And it is the most meaningful institution of the Brazilian health law, right? But the problems with SUS did not start with the pandemic. So SUS has been underfunded since its creation, and it also competes with a very robust private healthcare sector, right? And also another problem in 2016, for example, at the peak of this political and economic crisis that we had, there was this constitutional amendment that set a cap on public healthcare expenses, which resulted in a loss of almost $4 billion for SUS. So the result of this problem is that we had a shortage of intensive care beds and other materials, of course, personal protective equipment as well. So that existed prior to the pandemic. Also, and something that relates to what Alicia was saying, successful primary healthcare programs, which could be decisive in mitigating the pandemic in low-income communities, for example, have been undermined and by mismanagement, of course. But the real problem that I think we had, happened when the pandemic took over our political agenda. So as many of you know already, the president started to adopt this very aggressive and very denialist strategy. So first, he went on against his own government, his own Ministry of Health recommendations, which was, by our accounts, up until April 2020, a very technical body of experts. We had a very technical body of experts there. But he politicized the recommendations for social isolation, and he announced very early on chloroquine, for example, as a cure for COVID-19 without any scientific evidence, right? As a result of this attack, what happened was that our Minister of Health, who was a doctor, he stepped out, and in his place, there was this military official with no knowledge whatsoever of health, right? After that, the technical team at the Ministry of Health has been dismantled completely, and the institution highly militarized. So our problems really started to get worse after that. So I'm not going to go further on that, but the president has also been against the Congress attempts to contain the pandemic. So he vetoed almost all legislations setting out containment strategy in indigenous communities. For example, also indigenous communities was something that Alicia was talking about. And most of the law making it compulsory to wear masks in public spaces. He was vocal against the decisions coming from the Supreme Court, and also declared a war on governors who adopted this suspension of non-essential activities, right? And of course, the result of that, the most affected groups are without a doubt those who bear the historical discrimination and poverty, mainly Afro-Brazilians and indigenous populations. And I think for last, and then I'm going to stop talking, at the international level, I think there was a problem here. Brazil has wasted these historical opportunities to exert some kind of leadership. Traditionally, Brazil is quite important to the health area sector, but with our shift in diplomatic orientation, the country has turned its back on multilateral initiatives. And then I'm just going to say this 3 main points that I think we need to get better, and then so that we can discuss. I think first it's important to increase public investments in public health sector, just like our SUS, that needs to be increased. Second, it's important to maintain this social engagement in a democratic front. And third, for Brazil specifically, we have to restore some kind of leadership in global health by means of alliances and international commitments. In that way, I think we'll be prepared for maybe the next pandemic. So I think that those were the points that I would like to share with you about SUS and Brazil response to COVID-19. Thank you very much.
Oh, wow. This was, I think we'll clap for everyone. This was an amazing round of introduction. So this was really wonderful, Danielle. And I think many countries, also more affluent countries, have seen this same sort of underfunding of the public sector, where what seems like a very strong health system has been eroded through outsourcing, sort of cheap labor, part-time jobs that help spread the virus in many places, but also sort of health systems where emergency where sort of the pile-ups where had been built down, also where the intensive care units were built down and so on. So I think that this is one very sort of the long-term structural erosion of strong health systems is something that many countries have seen. And I also think you really illustrate what happens when, or which is what's also the case in Zanzibar, what happens when the pandemic becomes politicized, when it becomes a matter of sort of political mobilization or positioning. And now that also erodes the structure, whether it is to promote the Swedish response or it is sort of to dismantle the governance in the country. So this was super important. And I think that although these are three really different contexts, there are a lot of commonalities, but also a lot of things that I think many, probably those of you who are here can recognize much of this, and also online. And please contribute if you have things that you think should be part of this discussion, or you have questions, because I think that there is lots of commonalities. Yes.
Yeah, I just want to bring one issue to the table, that because there are around almost 50 master's students here that attended a full-day course on human rights. And we had a discussion this morning, a really interesting discussion. And we had cases from India, from Brazil, and from Nigeria and Poland, where we discussed health and human rights issues. And what was interesting to see across all these settings, one topic came out to be very important, and that was the inequalities between urban and rural areas. And that was mentioned in all countries, that you see much better access to healthcare in larger cities and a neglected rural population in all these settings. That was the main issues. And I think that is also important for COVID, the COVID pandemic.
Which also sort of shows how inequalities are then manifesting in the health system. Yeah,
in India, like there are governmental hospitals without any physicians. Huge problem with absenteeism. No health workers, they work in the private sector in the larger cities. So, and that's, of course, very political. And in Zanzibar now, 2 weeks ago, they shifted from a decentralized health system to a more centralized health system. So that's also, it's a small setting compared to India, for example, but of course it's, they make, at least they make it explicit and maybe easier to manage centrally, but then you have a problem with including the communities in decision making.
Absolutely. Which also goes to this question of what participation means and how that can be done meaningfully. But Ali, now that you've been sort of hearing from the other panelists, do you have any sort of thoughts on how these how the differences that you see are affecting and how they're differently affected by the global health governance?
Sorry, took a little while to unmute. So I really appreciated all of those different perspectives. I think, you know, in the, it was sort of this is a novel pathogen, and it swept across the globe incredibly quickly. And many states who, again, were facing shackles of debt and austerity with indifferent government regimes and hollowed out institutions, face sort of this Scylla or Charybdis situation of lockdowns and quarantine. And I agree with Camila. I would say there have been these dueling camps of expertise, the public health people and the economists, but that has not democratized decision making. So lockdowns and quarantine, and Peru locked down quickly. Argentina did as well too. And the other extreme of Tanzania, Sweden to some extent, Brazil, obviously, the United States in many ways, state by state. But both of those alternatives, I think, revealed the underlying pathologies of social inequality and institutional failures. And I think that I'm happy to talk specifically. There are some specific lacunae in international law and human rights that I think need to be addressed moving forward. But I'm not sure if all of the participants here are law students or lawyers. I would add one thing on the SUS in particular, because it's such an interesting example. The SUS is an extraordinary accomplishment of Brazilian democracy. And it was not adequately, there's participation built into the model of the SUS, real participation, not tokenistic consultation. But not just, it's very complicated. Brazil is a sprawling country. There are municipalities, there are states. Danielle can explain this much better than I can. But it's also been hollowed out through these agreements or convenios with the private sector. So much of the financing that should be going to this extraordinary democratic institution is siphoned off by the private sector, which only serves a small percentage of the population. And those agreements are completely or virtually completely, Danielle can correct me, unregulated. And there's just not a lot of parameters or governance around them. So I think I'll stop there and let other people, if people have specific questions about the international health regulations or other things, I'm happy to answer.
Thank you, Ali. Camila?
Yeah, I think that trying to relate with what Alicia was saying before on the neoliberal mechanism and what you say about the disparities between the rural and the urban is that I think that the COVID has also shown the useless of these indicators for health indicators and development indicators for urban poverty. Yeah, and yes, there are more health facilities in some urban settings. So it's more geographic accessible, but that doesn't mean that they are able to provide the care that people need in the facilities. So it is a different kind of barriers that people are facing in the urban settings, and also all this planning of how to distribute the health facilities are also basic on this distribution of the size of the population, and of course the rural population is dispersed, and that, so then you don't make there is no reference capacity in some parts of in the rural areas across the world. So, but I think again that because we are understanding this as a only cost benefits analysis, that we need to put this variable in the table, but it's not the only one, and we need to understand to try to fix the health system that you can make this referral system to work. In the case of Peru, also the case was that we closed down all the reference system because we closed down primary health for many months. So we say people, you have to come to the hospitals, and the hospitals were not so close, and people were afraid of hospitals because they were full of COVID. So then the people have been facing really big difficulties and to have access to healthcare. And related to this is that this idea that you buy because public services are inefficient, so you need to buy to the private, and this idea that this is cheaper without any evidence that this is a cheaper way to do the things. And just before the pandemic, we were working on a book with some colleagues on the corruption risk they call, but it was more like on how this the market of healthcare has been is now in Peru, and all these perverse relations that you allow to buy to the private, because it's just this ideology that is the public services buy to the private, that is going to be better, but it seems that it's much more expensive. There is no control. It's absolutely dark, so there is no control on how much you have to pay, and that for the same treatment. We discovered that, for example, for cancer, people were getting radiotherapy that in a hospital they were going to receive 12 sessions, that was okay. But in the private sector, and the medical doctor was from the private sector, putting the money in the pocket for each radiotherapy, sometimes women were receiving 50 sessions of radiotherapy. What is this affecting the health and the budget from the state is something to understand. But I think this understanding that the private is better and is less corrupt is something that we have to question, to challenge, because we need to see all these costs and how to invest really in the better way the public resources, and I think that is not has been in the debate, and we are still now we are continuing in that kind of discussion here. The World Bank has come with and many actors with promoted public-private partnerships as a way to go out from the pandemic, without again much evidence of how this is going to affect and what is really the capacity of this kind of interventions. What we know is that this kind of intervention is mainly at the hospital and not at the primary care, because they are not interested, and they are not going to be interested in rural areas. So we need also to challenge this idea that the private and the market is going to save us from this kind of situation.
Thank you, Camila. You wanted to...
Yeah, I just got some reflections regarding the work in Zanzibar related to this, because the COVID pandemic is ongoing, will probably do so for 10 years more. A new pandemic can come. And then what the focus in our work in Zanzibar is to also try to protect other essential services. And in our work with revision of the essential healthcare package, we do a very detailed modeling exercise trying to assess health benefits, but we also try to engage multiple stakeholders. And what we found is that all stakeholders at the high level, at the really community level, imams, patient organizations, everyone say that equity is important. You have to use equity as a criterion for prioritizing health services. And what has been interesting in the work in Zanzibar is that it's very challenging to institutionalize equity as a criterion for priority setting. Maximization of health is another important criterion, and that is much easier to model. You can just count the cost and you can make some assumptions like we have seen with the COVID models. How many lives do you save? But equity is much more complicated to bring on the table in the decision making, in the selection along the three axes that Alicia showed in universal health coverage, selecting services, and also in choosing what populations to cover and how to finance these services, out-of-pocket health insurance. And our model that we work on in Zanzibar is that maybe equity is most important to work on integrating when we are working on the implementation of services, maybe more than in the planning, because in the planning it can become very easily slogans like they said in Zanzibar and that they do in all health systems. They say all health services are available free of charge. And this is really not true, but it's a wish. And so equity in implementation is important.
Oh, this is, I mean, all of these points are so important. And I think that you've been between you, I think what I'm hearing is that there are some things that are really important and common. So one is sort of like Danielle was saying, your first point, or the other 3 points is that you need to strengthen the public funding. You need to strengthen the health system in terms of public funding, which also relates to this, what Camila was saying, trying to limit the influence of the market and the tensions that are in this double funding that we haven't really, or partnership that we haven't figured out. So that is one thing. So the finance part. And then of course, what also Camila spoke a lot to, actually we have our knowledge, the data we have are quite, we need better understanding of how, who has access, in which way to what. So, and then to protect the basic functioning of that system, which is about both of these in a way, but to protect also the non-COVID parts. And then of course, what you've been speaking to all of you, all to sort of the trust part, and the democratic and public participation part. So, and Alicia spoke to this in the keynote as well, that it's also about trust in the health system. We need populations who actually trust the system, but and that also requires the possibility to influence and participate. And how do we do that properly? So I think you pointed to really, really important things that need to be done. And this is at the domestic level, particularly. But I wanted, we only have some minutes left. I wanted to get back to you, Danielle, to say something more specific about the global level. So how do we need to reform global health governance? And then I'm going to go,
So yes, I really had a question here to the panel and to Alicia that said something about that. So I teach transnational law, and I'm quite fascinated by these new actors of global health governance. And these new actors are Melinda Gates and Bill Gates. So I'd like to talk about specifically about their philanthrocapitalism and maybe about a critical view on them, about the way they fund the whole system, because one of the problems that we had talking about global health and the problem with COVID was funding. So how do they come to the equation? Is it good the way they see the problems that we face today? What do you think? I think because they are quite fascinating as new actors of global health, I think.
Ali, do you want to take that?
I can take it, sure. Well, I have written and spoken extensively about this. I think the outsized influence of the Gates Foundation has been profoundly bad for global health, profoundly de-democratizing and undermining of accountability, et cetera. The Gates Foundation, for those of you who are not super familiar with this, they are the second largest donor to the WHO after the United States government, a private institution that is not accountable to anybody, which has made most of its money off of intellectual property, by the way, and has an ideological attachment to corporate monopolies. But they set the agenda, largely set the agenda in global health. They fund this other institution called the Institute for Health Metrics and Evaluation, which is that has become done much of the functions of the World Health Organization and the public institutions of global health governance. And so they are also involved in the measurement of of progress in global health. And around the world, they are involved in, setting up the policies and funding structures within countries, especially heavily aid-dependent countries. But they also fund academic research. And it would be very difficult to find high-level public health researchers in the United States, for example, where we have little public financing of public health that are not PIs or are not majorly funded by the Gates Foundation. And that has created a kind of sycophancy and obsequiousness and inability to be critical of the Gates Foundation in any meaningful way. This used to come up a lot because Melinda Gates is against abortion, and I've worked extensively in sexual and reproductive health and rights. But I think now what is most pronounced is the intellectual property angle, which, despite all of the good things that the foundation has financed and done, is going to be a stain on the moral conscience of all of the people who have taken money from them over years and years for a very long time. So that's my view.
Wonderful and provocative, Alicia. Very good. We only have a couple of minutes left of our time, but we have a question. Please come and ask it from the stage. You can come and ask it from the stage.
Yes, I think the first would be to Kjell for your. Okay. Sorry. Okay.
It's a good microphone, so you can.
Yes, thank you. Thank you for the presenters. Alicia, if you could reflect a bit on major human rights issues that COVID will bring to the fore compared to, for instance, the HIV pandemics, which has made human rights, a prominent issue vis-a-vis public health measures and healthcare provisions. That would be interesting. Also, in setting essential health packages, which in Ethiopia are very decisive, basically. They decide who gets what and for what. How participatory was it? And most importantly, how much of human rights norms do you include in setting these norms, these packages, basically? And if possible, quickly, Danielle, federalism in Brazil has been an issue vis-a-vis the COVID responses. If you could say a bit on that. Thank you.
Wow, really, 3 very good questions.
We have only 2 minutes.
Yes, but we'll go a couple of minutes over. So I'll go to, we'll take a round and then I'll let people answer your questions, but also make concluding comments. Is that okay? So then I will start with you and then Camila, Danielle, and Alicia at the end.
Thank you for good questions. So now I will switch to Ethiopia. BCEPS have also been involved in Ethiopia for 12 years now, and one of the tasks was the revision of the essential healthcare package in Ethiopia. That has been published, now being implemented. And human rights what can I say? It all depends on how you understand human rights. But I can say it has been very important in the development of the essential healthcare package in Ethiopia. But one of the challenges with the human rights-based approach in such concrete tasks is that it gives very little guidance on how to balance trade-offs. These thousands of questions you have to manage in actual concrete decision-making and priority setting. The human rights framework gives inadequate guidance. So not directly, but it's influenced. And the participation in Ethiopia is a challenge. It's now 105 million people. How can you have the interest of 105 million people included into such a decision-making process? And then you need to rely some way or another on task sharing and some kind of deliberative democratic techniques, trying to have representatives, having stakeholders, have good discussions, being critical, being open about the rationales behind decisions, having Delphi techniques and all kinds of techniques to tease out the arguments for and against. And this was done in Ethiopia in a very elegant and impressive way. And a lot to learn, and it's a start, I would say. Yes.
Thank you, Gianella. Then I'll turn to Camila. You can, I mean, I know that you have a lot to say to the questions that were asked, but also sort of general concluding reflection.
Well, I think that we need to rethink all of this, how we are structuring and understanding health and health system in general, and to bring back the issue of politics to this. I don't think that this is a technocratic approach that is independent from politics. I think that we have to make an effort to that and to understand the power imbalances, even for the participation, on what means participation on these settings. No, the population that has been historically marginalized and violated. So I think that we make this kind of measure. This can be super violent for some sectors of the population and no violent, and the same measure not be violent to other sectors of the population. And that is something that we need to understand better. No? And to understand these things of inequities, I think is at the core, and to try to read this with a better lens that will allow us to improve the health systems in general and in society. That I think.
Thank you, Camila. Danielle, federalism in Brazil.
Well, thank you very much for the question. I think federalism really shielded most of Brazilians from the worst response to the pandemic. So that's what happened when governors and mayors, they helped with the response to COVID. So that was the best thing that could have happened here in Brazil in face of our denialist government. So I think that's it.
Mm. Unless you want to also have something else you want to say in conclusion.
Well, in conclusion, just like Camila was saying, the importance of the political part and the importance also, I think about the second part that I said, something about this social front on forming this social front or democratic front. That's really important in the face of these new threats of the new pandemic, for example, and also a kind of leadership in global health, the importance of regional alliances. I think that's also going to be very important for the future, especially in the case of Brazil, our regional developing countries. So forming this kind of alliance and knowledge transfer. So I think that would be very important also for the future for us.
Thank you, Danielle. And I think that the sort of the emphasis on power and the importance of the politics and leadership has really been, I mean, I think that is so important and has been so important in so many places. Alicia, I leave the last word to you.
So I would echo much of what Camila and Danielle said. I think we need to, and I'll try to answer the question as well, we need to reclaim the public. Reclaim the public in the sense of public capacity and resourcing for health systems and other institutions, and reclaim public space for deliberation and democratic debate. And that needs to happen at national levels, but it also needs to happen at global levels. And I want to amend my comment, my somewhat overly dramatic comments about the Gates Foundation, because I do feel strongly that it has de-democratized global health. But when I say that it's a moral stain to have gone with the COVAX facility and the crumbs of charity to the rest of the world, and which with advanced market commitments and wealthy countries taking out vaccines as opposed to sharing technology access. I obviously think that human rights is important and the principles continue to be important. I would answer the question saying that, you know, I tried to outline some of this in the talk. I think clearly health systems, if we haven't learned in this pandemic that health systems are fundamental core institutions that are reflections of the quality of our democracies, I don't know what will show that. And we just need to work on the implications of that going forward. I would say that human rights it's not meant to be a tool to set priorities in that very granular way. And when some colleagues of mine suggest that the core obligations in a general comment might be used that way, I think it's misguided. Human rights is about process and principles and the fundamental equality of very diversely situated people in society. And ultimately, health and democratizing health is about that, about how we treat people, treat each other, and what we owe each other in meaningful democracy.
Thank you so much, Alicia. And I think that is a very important message to almost end with, because I'm going to read a comment that came in from Angola at the very end. My name is Margaret Nagakovi. I'm following the event from Angola in Southern Africa. And my comment on that would be about the secrecy versus security on the medical protocols to produce vaccine, and how it's difficult to create a social rationality around the reasons and efficiency of the vaccine in many local levels, such as community. In another hand, we're seeing that many of the government decisions are more in line with global institution orientations than local voices or necessities. And we notice as well, perhaps, that COVID are received in ways exacerbating political and economic tension, critical diseases such as malaria, renal diseases, and so on, that it's drawing attention away. So we didn't have a COVID clash, but we had a malaria clash on public hospitals where patients were literally sleeping in the hospital corridors. So this is very much emphasizing your point as well. So I think this is again sort of showing that we need to work at many levels, but also emphasizing the last point that you made, Alicia, that we really, and I do think that there is a growing awareness, a broad awareness of the importance of health systems as social institutions and the importance of health systems for exacerbating or ameliorating inequalities in societies. And I think that public discourse around health systems is one of the things that hopefully will happen on a more broad scale in the years to come. Thank you so much for following. Thank you so much for participating from Brazil, Danielle, from Peru, from Lima, Camila, from Boston, Alicia, here in Bergen, Arne, all of you. It has been a really, really good discussion. I look forward to hopefully being able to welcome you all to Bergen next year, and maybe we can continue. For sure we can continue. Thank you. Thank you all.